Move on. This is Leslie Emmerich. I'm the Director of Public Policy and Outreach for the Washington State Hospice and Palliative Care Organization. Welcome to our Palliative Care Networking call this morning. It's September 19th and at 7:34, so we're going to go ahead and get started. I'd like to do introductions from folks around the state, and let's start with Spokane area first. If you live in that northeast corner of the state, would you please introduce yourself? Take yourself off of mute.
Okay, I'm Colleen Burns. I am the Palliative Care Coordinator for Hospice of Spokane.
Welcome, Colleen. Anybody else from Spokane area? Okay, how about down around Tri-Cities area or anything in between on the east side of the state?
Jeanette Weber from Chaplaincy Healthcare in Richland.
Thank you, Jeanette. Anybody else from the far east side? Okay, how about Central Washington, Wenatchee, Ellensburg, Yakima? Okay, let's start down in Vancouver, Washington, Southwest Washington. Take yourself off mute.
Good morning, this is Candace Cheney, Nurse Liaison, Education Outreach for Assured Hospice LHC Group in Washington.
Great, thanks Candace. What about our lady from Peace Health down there in Vancouver? We can't hear you. All right. Anybody from the west side of the state, Seattle area, Everett, clear up to Bellingham? We're having. Go ahead.
This is Cynthia Tomic, and I'm the manager of palliative care at Evergreen House in Kirkland.
All right. Who hasn't introduced themselves yet? Please do. We've got a number of callers on the line. Could you please introduce yourselves? You have to take yourself off mute.
Can you hear me?
Yes.
Yes.
Okay, this is Sheila Brandenburg with Palliative Care in Omak, Washington.
Hi, welcome.
Thank you.
Anybody else? Okay, well, we've got a number of different callers on the phone, but we'll go ahead and start the presentation. Cynthia, would you like to introduce Marie?
Oh, sure. Thank you so much. So once again, I'm Cynthia Tomic, and I'm the manager of palliative care at Evergreen in Kirkland, Washington. I'm also the chair of this committee, and we are very fortunate this morning to have Marie Eaton with us. And Dr. Eaton has several roles. She is the chair of the Northwest Life Passage Coalition. She is also Professor Emerita of Humanities and Education at Fairhaven College at Western Washington University in Bellingham. And she's also the director of the Palliative Care Institute at Western. The Institute is a partnership with Northwest Life Passages Coalition and other community agencies and volunteers. One of their goals is to transform palliative care in Whatcom County and support human response to living and dying. The goal of the organization is to create a healing community by providing a space where people living with serious illness or facing the end of life don't have to be cured to heal. And they build on collaborations among those both inside and outside of the medical industry, reclaiming palliative care as a community responsibility. And the rest of her bio is in the invitation to this call, but I thought that that was so beautifully worded and such a grounding framework that I wanted to start with that. So with that, I would like to turn it over to Dr. Eaton for her presentation.
Well, thank you so much. And I am thrilled to be here with you this morning. And so the invitation that I got was to talk with you a little bit about the work that's been happening in Whatcom County. And so this presentation is going to focus on the Northwest Life Passages Coalition Blueprint. And I'm going to walk you through the process that we went through in order to build this blueprint for creating a community of caring for those with serious illness and facing end of life. So that lovely introduction really said what the Institute was, but I wanted to sort of ground my discussion in the role that the Institute has at the university and in our community. So the Institute is a new initiative. We are in our second year of Institute status. Before that, we were an initiative, and it takes a long time to go from initiative to institute at a university, but we now have Institute status. And as was just said, that we're really looking to improve care for those with serious illness, and that we're trying to actively involve multiple domains of our community so that it's not only the medical profession, but also other service agencies and community members who are participating in improving palliative care in our community. So the Northwest Passages Coalition has membership from many agencies in Whatcom County. And you can see here that our goal is to create a community of care and support for patients with serious illness or facing end of life. And that it includes the sort of logical players like the Family Care Network and the Peace Health St. Joseph Medical Center and the Whatcom Hospice, but it also includes multiple players from other social service agencies and facilities that serve the people with serious illness. And the Area Health Education Center for Western Washington is now sited in Bellingham, and so they also have membership, because Whatcom County is considered a rural county, even though Bellingham itself is a fairly urban environment, but we serve the whole county. So this process began in 2014 when there was sort of a happy collision between some efforts that were happening at the university and some efforts that were happening in our community. And we realized that there were quite a few services for seriously ill or dying people in our community, but they were very uncoordinated. So all the little canoes were going in different directions. And our goal was to get these little boats aligned and to do a better job of communicating and collaborating about those services and to identify the gaps. So as we began to look at the coalition and this creation of this blueprint, the Whatcom Alliance for Health Advancement, which is a local group that convenes conversation groups around health care issues, they convened a task force in 2014. And this task force was charged with this question: what would it take to transform Whatcom County into a center of end-of-life excellence? And that scope enlarged as our discussions went forward from end-of-life to end-of-life and serious illness. We explored the existing resources for those with serious illness, including advanced care planning, palliative care services, community understanding about death as a natural part of the cycle of life. We identified the gaps and the areas of need, and then we wrote a blueprint to guide the improvement in Whatcom County, and we revised that blueprint this year. So here are the blueprint pillars, and I'm going to sort of walk through each one and give you some examples of the kind of work that we're doing here in Whatcom County. Obviously, the first pillar is good clinical care for those who have serious illness or are facing end of life, and that in our community falls in sort of three domains. There's the inpatient palliative care team at Peace Health St. Joseph's Medical Center, and that team is stronger and stronger each year. I think probably you're seeing the same things in your own clinical environments, that more and more people are beginning to talk about palliative care, and more people are getting the skills and competencies based in palliative care. So we have a terrific team inpatient team in the hospital. We also have a wonderful hospice. Whatcom Hospice has had a long history of service both in the hospice house and in community settings. So very robust hospice program up here. And then what we're really working on is to try to build a better outpatient palliative care program, because as with many palliative care situations, clients want to be at home, and yet the reimbursement systems don't reinforce home care. They reinforce revisiting hospital rooms and hospital emergency rooms. So we're working together on some small outpatient support programs, and I'll talk a little bit more about how that's happening. A second very strong initiative is advanced care planning, and the lead people in that initiative are the Whatcom Alliance for Health Advancement, and they're using the Gunderson model and the Palliative Care Institute. And Peace Health has now just begun a pilot program up here in their clinics as well. So this slide should be actually edited to reflect that change as well. The third area is provider training, and as many of you are, I'm certainly aware, many clinicians do not get training in palliative care. The training is focused on curative care. And so together we've been trying to offer more opportunities for clinicians to gain competencies in palliative care through a series of lectures or conferences or workshops, and most of them carrying CME opportunities. And then the piece that the Palliative Care Institute has really taken the lead on is what I call community education and activation. And as this population ages, and the population over 65 is going to double by 2050, so there are more and more of us in this group of older adults who are going to need palliative and end-of-life care. We need to do a better job of educating the community about what their choices are and the importance of making choices before the medical crisis happens. And so we do a lot of community activation work. And then sustainability is really about thinking about where are the funding streams for palliative care work, and where are the places where we could exert our collective pressure as a coalition into the changing of Medicare and Medicaid laws so that palliative care might be better reimbursed, and some of the other kinds of issues of sustainability. So when we think about each one of these pillars, and we'll start back with palliative clinical care, as I mentioned, we are beginning some work with outpatient palliative care. The Family Care Network here, which is the collection of many of the family physicians, they have begun to run palliative care clinics. They've begun to do in-house training for their physicians in better advanced care planning, so that advanced care planning is becoming part of the well visits for the Family Care Network. And they have a couple of nurses who are doing in-home visits on a very small scale. The Peace Health St. Joseph's Hospital Medical Center is doing some better coordination of their palliative care work, so there's now, in terms of administrative structure, there's one person who is linking hospice, the cancer clinic, and the senior health center, and the in-house palliative care. So I think there's better coordination of services across those domains. We've also pulled in players from the Lummi Tribal Health Center to work with the communities and in the Lummi Reservation and the Nooksack Reservation on better providing a palliative care in a culturally competent way in that community. And then we are working with the professional communities who provide complementary and home health care and skilled nursing facility care on better palliative clinical care. And as Atul Gawande said in his book, it's more than a medical intervention, and that's part of the way that we framed this. And as the introduction said, we're really trying to reclaim palliative care as a community responsibility for the whole community. So when I talk to my colleagues, I say my generation took back natural childbirth, and we're going to take back natural dying. And I don't mean that as a disrespect to the medical profession, but I think in both cases we over-medicalized a natural human process and gave up our own community responsibilities for being part of those very natural parts of the human life cycle. So we're trying to bring that back, that connection and collaboration and partnership between the medical profession and the community. And we're really working with this newer model of palliative care goals, which I'm sure most of you are very familiar with this slide, that we're no longer thinking about aggressive life-prolonging care up to the point of 6 months till death, but actually thinking about the ways that palliative and life-prolonging care work together, particularly in serious long-term chronic illness, and the ways that hospice care also leads into bereavement care for the family. One of the things that I want to call out, because I think it's important for us to think about, and those of us who are working in palliative care, is that there are disparate impacts in minority communities, and each of you are living in areas where you have a particular minority community you may be working with. But for us here in Whatcom County, it's largely the Hispanic community and the Native American community. And those communities of color often experience suboptimal end-of-life care, and there are multiple reasons. Sometimes there are institutional barriers. There's lack of insurance or underrepresentation of their own people in the medical careers, so they don't see their own culture reflected in the care they're getting. There are also cultural barriers in terms of lack of training for those of us who are not from those communities about the cultural values and practices that are important. And there are also individual barriers. There's a lack of trust in the healthcare system because, frankly, there has been historical discrimination that those communities have experienced. So that means that as a group, for example, the American Indians or American Natives have a lower incidence of most types of cancer than non-Hispanic white Americans, but they are more likely to be diagnosed with late-stage disease, and their cancer survival is generally poorer than other groups. So their access to palliative care, hospice, and end-of-life services lags behind the rest of the nation. So we have been, one of the foci we have had in the last 2 years is to do more work to develop better cultural competencies related to palliative care, and I'll share one of those with you in a few moments. I just think this quote from Dr. Judith Salmon-Cower, who is the medical director for the Mayo Clinic Hospice, is an important reminder, is that we need to take the time to learn the unique customs, religious beliefs, and practices of the people our services are directed to. And this frame of culture will determine how patients and families receive information, make decisions, and try to find meaning and direction in the force of potentially life-limiting or end-of-life situations. One small example, which many of you may be familiar with, but was new knowledge for me as I began to dig into this work, is that if you are from a Spanish-speaking culture and Spanish is your mother tongue, the word hospice has often a negative connotation because it also means orphanage, and so it carries with it a sense of abandonment. And so working with native-speaking Spanish speakers, we finding different language to talk about the options of hospice sometimes will make that initial conversation go better than it might have otherwise. So that's just a small example of why culturally responsive care might be important. So here's some of the current projects that we are doing to improve palliative care in Whatcom County. So as I mentioned, there's been changes in staffing for the palliative care services at Peace Health St. Joseph's Medical Center. We've begun the small program in outpatient palliative care support in both the Family Care Network and the Peace Health St. Joseph Medical Center are beginning those services. We're strengthening our connections with the Lubby Tribal Health Services. So the second pillar is advanced care planning. And if you work in palliative care, you have, I know, experienced the chaos that can happen in a medical crisis at the end when desires about end-of-life care have not been discussed. So there are a number of initiatives in our community related to advanced care planning so that we're providing our community with many, many opportunities to talk about advanced care planning and many avenues for completing those forms and filing those forms. So the WAHA uses a program called End of Life Choices that's based on the Gunderson model. Palliative Care Institute sponsors multiple community events related to advanced care planning. There's some community members who are using the End of Life Washington Advanced Care Directive forms in offering workshops, and Peace Health has begun the Honoring Choices program and also has an advanced care planning tab on the home screen in emergency care. So I know I'm talking to the already committed, but just a reminder that 80% of people think it's important to talk about advanced care planning, but only 30% have had that conversation with their loved ones. And only 7% have actually talked over these preferences with their doctors or their palliative care providers. And only 35% of general practitioners initiate those conversations with their patients. I think these data are beginning to change now because with the new Medicare law that allows billing for an end-of-life conversation or advanced care planning conversation, I think that we've begun the important shift that needs to happen. But when I think about the goals of care, when the seriously ill patients were interviewed in this Institute of Medicine research in 2015, their priorities in priority order when they had a serious illness were to live independently, not be a burden, have their symptoms managed, and then last was to live longer. But as you are well aware, much of the care that people receive in a medical crisis at the end of life focuses on number 4 first. And so that a good advanced care planning conversation can help both the family and the clinicians make the choices that are most important to the patient. So we want to be the next La Crosse, Wisconsin, where 96% of people who die have an advance directive filed. And of course, the side effect of La Crosse's program is that they spend less on health care for patients at end of life than any other place in the country. So it's both, I think, a human issue, but it's also a financial and fiscal issue about planning for death. So we have a disappearing task force on advanced care planning that's run through the coalition. It brings together all the people in the community who are doing advanced care planning work so that we can share resources and information. We have clarified the Peace Health procedures for advanced care filing. So there's a process for anyone in our community to have an advanced care plan filed at our hospital. And we are a 1-hospital county, so it's important that these forms are there. We run a quarterly program called The Realities of Advanced Medical Interventions, which is an educational series for the community that unpacks what happens in an intensive care unit or in an emergency room. Because when lay people are offered the opportunity to do advanced care planning, often they're daunted by the kind of language of medical interventions, and so they don't, when they ask, do you want a ventilator or don't you want a ventilator, they don't know how to make that decision. In fact, that's not a good way to do advanced care planning, to talk just about the processes, but understanding what the statistics are on surviving CPR and surviving ventilation with certain kinds of medical crises can help people make better choices about what they really want, and to make choices about the quality of life that they hope to have after the intervention, rather than simply focusing on the intervention itself. We have advanced care planning workshops that are run the first Monday of each month in the Whatcom County libraries, and the seminar travels around the county to a different library each month, and those are free. And then we're doing a program this spring called What's Up, Doc? We're Dying to Talk, which is trying to motivate younger people to do their advanced care plans. So we are really reaching out to the high school students and college students and young adults to say, this is important for you as well. And if I were queen of the world, people would file their first advanced care plan when they got their driver's license. And then they would revise it either at every decade birthday or every important life event. And that's the kind of attitude we're trying to cultivate in this community. Provider training, we do a lot of conferences, workshops, lectures. So we did one last spring called Care of Latinos with Serious Illness, a Palliative Approach. And this was a wonderful program that was it's sponsored by the Cambia Foundation and run by Familias en Acción, which is a community agency in Portland. And they did a great job of talking about the challenges of access to palliative care for the Latina population. And so this was an important provider training for our community. We did a spring conference last year on helping till it hurts, care for the caregiver. And by caregiver, we meant not only those family caregivers that are caring for loved ones, but also all of you who are doing this work on a daily basis with seriously ill patients, and how do we nurture ourselves so that we can sustain the work. Our spring conference this next year, which is going to be on May 11th, is on pain management alternatives to the opioids. And we're going to be looking at the interventions like MDMA and the psilocybins and acupuncture and mindfulness and cognitive behavioral interventions and acupuncture as ways that we can think about other options besides opioids for pain management. We also the Institute works at Western in the RN to BSN nursing program, and we are including palliative care competencies for all the nursing graduates using the wonderful end-of-life models that the National Nursing Commission has put together. Wonderful, they're great modules. There are also a new initiatives at both Peace Health and FCN in in-house clinician training, and Peace Health St. Joseph's Medical Center has initiated a clinician education academy to do more work in palliative training. We have a health ministry nurses community in Bellingham and Whatcom County, and they're doing spiritual care training with their health ministry nurses. And then the Palliative Care Institute is sponsoring a new project to work on training all nursing home staff, including the non-professional staff, in palliative care competencies to try to create more palliative environment in skilled nursing and assisted living facilities. I wanted to share with you that another piece that we have that is something that you can access at any time. We have been working with the university to develop a digital archive of lectures and presentations from previous conferences, and it's called the CEDAR, which means contributing to education through digital access to research. So this is a national project for digital access that our Western Library participates in, and the link is shown there on the screen, and at that link you could reach all the presentations from previous conferences that we have done around multiple different topics. So that's a resource that's open to you. Just visit that link and you can watch the videos. The community education and activation piece is, like as I said, are largely the responsibility of the Palliative Care Institute, and we have multiple community conversations where we just get people together to talk about dying and the issues of dying. Lectures and events. The conferences, although they are often focused on providers, we always invite community members, and I think those conversations, having community members in the room, actually deepens the conversations that providers can have about end-of-life care. And then we've developed a resource website, which I will share with you as well. And then we do this little project called microgrants, where we offer community members a couple $1,000s to do something that they think will improve the situation about palliative care in our community. So here's some examples of some of the current projects that we've done in the community activation and education series. So we ran a series of what we call legacy letter workshops, and this is a very low stakes way to get people to begin to think about their own mortality. So they're not writing about their dying, they're more writing about what they hope people will remember about them after they die. We put on a concert called Moving the Bones, Lively Songs About Death. There's lots and lots and lots of songs about death, and some of them are funny, some of them are sad, and we did a whole evening of them, and it was well received. We're doing a Death Over Dinner event that is an advanced care planning workshop where people will come together for a wonderful meal and some robust conversation about their choices at end of life. We did a more serious conversation last fall, Death Happens, Let's Talk About Your Choices, in which we talked about some of the more challenging choices at end of life, such as death with dignity or the voluntary stopping of eating and drinking, and palliative sedation. And all of those lectures are available at that CEDAR site. And we're doing a workshop for the community this winter called Peace, Health, Rumors, and Realities, because there's a lot of stories that are passed around our community about what a Catholic hospital can and cannot do, or will and will not do, related to end-of-life choices. And we're working to clarify what is actually the truth about those stories. And then this is the community-based resource website that I wanted to share with you. And this is a community-populated site, and it links users with services related to palliative and end-of-life care. So if you think back to that early slide with the boats all going in different directions, the experiences of people who have serious illness is often one in which they are unable to find resources or they're overwhelmed. So the Whatcom Cares website organizes resources, and it has 3 sections. Resource section that points people toward local, primarily local, but sometimes statewide or national resources that will help them as they are facing serious illness or end of life. And then it has a library section where we've posted some articles that are written for lay people about serious illness or end of life. And then there's a stories section where people can share their own stories. So that this website was launched last spring, and it's just beginning to be populated. Couple examples of the microgrants is one, we did a back of the bus campaign. So a community member said, you ought to have something on the back of the bus. And so we did. It says, dying happens and we should talk about it. And it points them toward the Advanced Care Planning Initiative at the Whatcom Alliance for Health Advancement. And another person was bemoaning the fact that when she goes to the Hallmark store or to her local card store, when her friend gets diagnosed with stage 4 ovarian cancer, the Get Well Soon card just doesn't work. And so we built an empathy card project. So this is a portable station that we take to all the conferences. And we've also begun to work with community members, church groups, school groups, where they can build their own cards that say, have that the kinds of caring comments that they would like to make when Get Well Soon doesn't work. We have lots of other partners in our community who are also working on community education. So there are groups that do music at the bedside. We have a robust death cafe, and we partner with many of the support groups in the community. So it's not just us doing that. And then the sustainability pillar, as I mentioned, is really important, that we see ourselves as advocates and provide leadership related to the needed policy changes. So we're going to be meeting with the Accountable Communities of Health folks this next Monday to begin to talk about the ways in which some of the Pathways projects can be focused on palliative and end-of-life care. And we're trying to actively lobby for different payer and funding models and for revised metrics in the way that healthcare is evaluated, because as you are well aware, it's when the evaluation metric is on getting better when you're dying is different than getting better when you have a broken leg. And then we are also trying to do more coordinated work in philanthropy and grant writing, because all the separate agencies that work with palliative end-of-life care often are looking toward the same donors, and so we're trying to do that in a more coordinated way. So our progress since 2014. So we are continuing to evolve our community and cultural responses to living with serious illness. So that we have formally formed the Northwest Life Passages Coalition, and we meet monthly. We implemented an advance directive campaign that has multiple arms. We've established palliative care competencies for clinicians and have begun to work with local clinician training groups to embed those competencies into their training programs. We've taken first steps toward a community-based outpatient palliative care service. We've launched this community education and activation series. And we're developing a better coordinated approach to philanthropic funding and opportunities for piloting innovative care payment models. And then we revised the blueprint, so to bring it back up to date. So that's what's happened in our blueprint, and I'm happy to answer any questions. And I hope that you do take the time to visit both the Palliative Care Institute site and the whatcomcares.org site. I think that would be wonderful. So I'm going to get back to the GoToMeeting thing here. So I'm happy to entertain any questions or conversation.
I'm going to hop in here. This is Cynthia. Dr. Eaton, that is amazing. I am sitting here with these sparkling eyes looking at all this work that you guys are doing in Whatcom County. It's incredible what you're doing. Thank you so much for sharing all of that.
Well, I hope that you can be inspired to bring people in your community together as well, because I frankly, in 2014, when we first sat down with the initial task force, I thought, I don't know if this is going to go anywhere. And it has gone someplace. So there are probably people in your home community that would, that if you can begin to bring people together, it's amazing what can happen.
Mm-hmm. Wow. I do have several questions. I'm just going to start with one and then make space for other people's questions. Mm-hmm. Way earlier in your presentation, you talked about having a process for anyone in the community to be able to file an advance directive in EMR. Are you able to speak about that a little bit? How did you come up with that? That
actually took, that's when I think about the advocacy work that the coalition could do. That's one of the places where the Northwest Life Passages Coalition was actually able to influence the way Peace Health St. Joseph did their medical records. So we are very fortunate to have members on the coalition from Peace Health St. Joseph's, so that they were right there at the table as we began to talk about one of the challenges that Washington State has is that there is no state registry for advanced care directives. And because we are a one hospital county, it means that most people who get seriously ill in Whatcom County are going to end up at Peace Health St. Joseph's, even if they are not Peace Health St. Joseph clients in the clinics. So we just began to talk in our advanced care planning initiative about how important it was that there be a central registry in our county. And we worked a lot with the upper management at Peace Health St. Joseph's, and they have a new process now. And I could send Leslie the formal document that, I mean, we got this lot just this summer finally to have a process for people to file their medical records. Does that answer your question?
Yeah, it does. Thank you so much. How about other questions for Dr. Eaton?
Dr. Eaton, this is Leslie. I just had some questions about the funding pieces. I think that has continually come up in the conversations that I've been in with the Department of Health. You know that they're working on a funding model and trying to get grant funding from that. There's been meetings with the Healthcare Authority about how to fund palliative care. Can you talk a little bit more about the different payment and funding models that you're looking at, and what do you think we could do as a group or even our association to help get these different payment and funding models a little bit more standardized? I don't think it has to be a cookie cutter approach, but certainly figuring out a way for insurance companies to be able to bill for palliative care. What do you think the best thing that we could do to help promote that?
Oh boy, that's a complicated question, Leslie. So, you know, I was just reading some of the research about palliative and end-of-life care and looking at where are the big, you know, so part of it is persuading the people who do the payments that it's to their benefit to do better payment for palliative care. And part of that persuasion is focusing on those clients that are the cost the most at end of life. And the data that I was looking at the other day, sort of like they fall into three different categories. So there are the people that where there's some crash, but they recover. So they have a myocardial infarction, but they actually come back to health. And there's a lot of healthcare dollars that are spent on them, but and we could say that those are healthcare dollars well spent because the person comes back to at least pretty good functioning. Then there's the group that is actively dying, and unfortunately, because many people have not made active choices, they are the healthcare profession is left with their hands tied, because if someone comes in not breathing, unless they have an advanced care directive, your role is to try to save them. And often that means aggressive care that is unwarranted and unneeded because the person is going to die anyway within the next couple of days or in the next couple hours. But without some clear guidance from them about their choices, I think, so that's important. But the part that I think where the healthcare savings can really happen, and where I think we could be working with our insurance companies and payer systems to think differently, is that chronically ill group. It's the people with chronic obstructive pulmonary disease and unmanaged diabetes, and that are the revolving door emergency room visitors, because there's no model for in-home palliative care. And I think that this takes lobbying, and in a sense that, you know, as long as hospitals are reimbursed per intervention rather than having a single payer model, then we are stuck with hospitals not being as, fiscally, whether they're morally in favor of outpatient palliative care, fiscally, it's not a good decision for them to build robust outpatient programs because they don't get reimbursed for them. And I think that means changing the way reimbursement happens, and that means working with legislators and legislative initiatives. That's probably a longer answer than you wanted.
Actually, a perfect answer.
I just want to say one other initiative that I neglected to mention that's happening in Whatcom County is that the Whatcom Alliance for Health Advancements working collaboratively with the fire department and the medics, so that some of the roles for those medics is not just going to clients' homes when they have a medical emergency, but actually visiting sometimes to make sure they're taking their when you get the people who are the heavy users, you know, those medics bring the same person in 5 or 6 or 7 times in a year. And so they're starting now to do advanced check-ins with them to make sure that they're actually taking their medicines and to try to avoid that 911 call.
Yes, we've been participating with the state group that's been working on that concept. So have you seen any models for legislation from other states that could be used with the legislature? I'm also the lobbyist for the Hospice Association, and we did have a piece of legislation a few years ago that allowed insurance companies to voluntarily pay for palliative care. I've not heard how well that's going, but was going to follow up on it this next year. But if you come across any state legislation or something that kind of helps with that funding and payment model that you think we could use with legislators, I would certainly like to see that so we could share it with our.
I think we're just beginning to explore that. So I think one of the places we're starting to intervene is with this accountable communities of health opportunities to develop these pathway models. And I think, they've got a pathway for high-risk pregnant women. Well, I think if we can persuade some of those accountable communities of health to take on palliative care as a pathway, that's so there's a serious and chronic illness pathway. I think we would begin to it would begin the conversations, and that's the place we're starting. I have not seen other great. There are the COPES program and some other programs that are looking at some of the models, but I don't have something to offer really yet. But when I do, I'm happy to share it, because that's part of what we're really trying to tackle right now.
Hi, this is Charmin.
Hi, Charmin.
Can you guys hear me?
Yeah.
Hi. Marie, thank you so much. This was awesome. I, living here in Bellingham, I was really thrilled to know that you'd be able to share this with the group. So thank you much for your time this morning. It's a great presentation. A couple of comments is regarding the question of insurance payers. I know that Regents for the Northwest has created a multi-state palliative care benefit. So it's being woven into the benefits for Regents patients. Hopefully what they're hoping is that there'll be a model or perhaps shame other insurance providers into doing the same. So Leslie, I think this mission did really help them. My other question would be more toward, you've come so far. When I think about this starting back in, it seems like it much longer ago than 2014, but one of the key things that is, I know as a community member, the fact that this came as a partnership involving the university made it very community oriented right from the start. And I think that's the hard thing for communities, is the need for this. The identity is in the medical community, but it's hard to know how to make that bridge. So if you could just, offer sage guidance or sage advice about how to start things.
I appreciate, Sharman, that you brought that up. And when the Whatcom Alliance for Health Advancement formed this initial task force, they asked me to chair it. I am not a clinician, and I should have made that very clear at the beginning of this presentation. I taught classes about death and dying for a long time at the university, so I have a lot of knowledge about the processes and challenges of end-of-life care, but I am not a clinician. And I think they asked me to chair the committee because I wasn't a clinician. However, when the roster happened, when the roster was given to me of all the community members, and it had, Dr. Meg Jacobson, medical director, Whatcom Hospice, and all the bunch of physicians and a bunch of nurses and a bunch of other clinical providers who were on the initial task force and had all their affiliations. And then after my name, it said consumer, and I was furious because we are all consumers of healthcare, and everybody in that room is a consumer. And so right from the very start, one of our very first conversations in that task force was the importance of community voice and community participation in changing healthcare and making palliative care more robust. That we cannot just give this over to the medical profession and say, do it for us. It doesn't work. And so that I would encourage you, if you want to get this initiative in your community, you have community members who are passionate about this in the same way I am, and bringing them in as full members of the discussion about how palliative care and end-of-life care needs to change is so important. And I will say, in the first year, it was a battle to keep reminding people this is not just about medical care, because if you look at the palliative care wheel, about 20% of the care is clinical, and the other 80% is all the other attendant services that come around it. And when I'm talking to students at the university, I say, this is the next career opportunity, because it doesn't matter what field you're in. You can be in music and you have a role in palliative care. You can be in, you don't have to be a doctor or a nurse in order to make a significant contribution. So I think that's been an important piece. And I will also say that at every conference, as I mentioned, we invite the community to be full participants in that conference. And I think that our model of bringing clinicians and community members together to talk through the changes that need to happen in palliative care has been really powerful. So I appreciate that. One other comment I wanted to make, thanks for the reminder about Regents, Sharman, but another initiative that we have undertaken, and I think it's something you can do in your home community, is that we're working with employers in advanced care planning to begin, so that they will begin to see advanced care planning as an employee perk. And so, for example, at Western, if you have completed an advanced care plan, you get so many wellness points. And if you get enough wellness points, you have to do other things too, like stop smoking or exercise or whatever. But when you get enough wellness points, then you get a reduced insurance rate on your health insurance. So there are ways that we can build in sort of the reinforcement systems for better palliative and end-of-life care and better planning to even if the national laws haven't followed there yet.
Dr. Eaton, this is Cynthia again, and going back to inviting the community to events, how do you advertise? How do you get the word out so that community members are aware of the events, so that they know they can attend?
Yeah, so we now have a quite robust email list from previous attendees. We also, I would say that the Death Cafe initiative in our community started about the same time as the coalition began. And so that's been a good place to begin that networking. I give talks on the radio. I've given talks at the public library. So trying to just reach out to the community. And I would say that when I first started teaching death and dying, it was really hard to even find a book to use with students. And now, of course, if you go to your local bookstore, there's 1,000 books about end of life and the challenges of end of life care. And so I think the community conversation is starting to happen in your community. Is finding where are the pockets where people are actually talking. Senior center, I go to the senior center and talk with them. Our biggest challenge, frankly, particularly with the advanced care planning events, is getting younger people to participate. And so that's why this next year's event is really targeting younger people. And we're working with some students at the university and some other groups to reach out to younger people to persuade them that this is an important conversation for them as well. But it takes time to get that group going, but we have a pretty solid group now.
Thank you so much. I just realized we're at the end of our time. I wish we had so much more time. I want to ask the callers if there's anyone who has a final burning question before we end. Okay.
No, just a huge thanks. This is awesome.
Okay, well, thank you. I really appreciate the opportunity to talk to you all. And I hope you visit these sites. And if you have any other questions, I'm happy to answer you by email or by phone.
Dr. Eaton, thank you so much for presenting to us this morning. I, for one, feel very inspired. So thank you so much.
Thank you.
Thank you.
Okay, everybody, we'll see you next time in November for our call. Thanks for joining. Wonderful day. Bye-bye, everybody.
Bye.
Bye-bye.